Good morning. We are going to talk about the laryngeal mask airway. To begin, where does it sit in the modern classification of airway devices?
Good morning. The laryngeal mask airway is the prototype supraglottic airway device, sometimes abbreviated SG or S-D, supraglottic airway device or supraglottic airway. These are devices that sit above the glottis, sealing around the laryngeal inlet without entering the trachea. They occupy a middle ground between the face mask and the tracheal tube, providing a hands-free airway with less hemodynamic disturbance than intubation, but without the airway protection of a cuff tube below the cords.
Who invented the LMA and when?
The laryngeal mask airway was conceived and developed by Dr. Archie Brain, a British anaesthetist, at the London Hospital. He worked on the design through the early 1980s, took out the first patent in 1982, and the device was introduced into UK clinical practice in 1988. It has since become one of the most important innovations in modern airway management, and is incorporated as a rescue device in essentially every major difficult airway guideline worldwide, including the Difficult Airway Society guidelines.
How would you classify supraglottic airway devices?
Several classifications exist. The most clinically useful is the functional classification by generation. First-generation devices are simple airway tubes with a perilaryngeal seal, for example the classic LMA. Second-generation devices have additional features specifically designed to reduce the risk of aspiration and to provide a higher seal pressure, most importantly a gastric drainage channel. Examples of second-generation devices include the LM ProSeal, LM Supreme, the iGel, and the LM Protector. An additional classification is by method of sealing. Inflatable cuff versus non-inflatable thermoplastic gel, the iGel being the leading example of the latter. A third classification is by intended use. Routine airway, intubating conduit such as the fast track, pediatric or specialist devices such as the LM, a gastro for upper endoscopy.
Tell me about the classic LM in detail.
The classic LM is the original Archie Brain device, the prototype first-generation supraglottic airway. It consists of an airway tube, an elliptical mask at its distal end, designed to seat in the hypopharynx around the laryngeal inlet, and an inflatable cuff running around the rim of the mask, inflated through a pilot balloon. The mask has aperture bars, two small bars across the opening, to prevent the epiglottis from prolapsing into the airway tube. The tube is reinforced internally and connects proximally to a standard 15mm catheter mount for the breathing circuit.
Material.
Medical-grade silicone, which is autoclavable. The original classic LM was reusable, validated for up to 40 cycles of autoclaving at 134 degrees Celsius. Disposable single-use versions made of polyvinyl chloride were introduced subsequently and now dominate practice in many institutions to eliminate cross-infection risk.
Sizes.
Sizes range from size 1 for neonates under 5 kilograms, up to size 6 for adults over 100 kilograms. The intermediate sizes are size 1.5 for infants of 5 to 10 kilograms, size 2 for 10 to 20 kilograms, size 2.5 for 20 to 30 kilograms, size 3 for 30 to 50 kilograms, size 4 for 50 to 70 kilograms, and size 5 for 70 to 100 kilograms. Each size has a maximum cuff inflation volume, marked on the device, ranging from 4 milliliters for size 1 up to 40 milliliters for size 6. The cuff should be inflated to a pressure of no more than 60 centimeters of water to minimize mucosal injury, measured with a manometer in practice.
What is the typical seal pressure of the classic LMA?
Approximately 20 centimeters of water, sometimes called the oropharyngeal leak pressure, or OLP. This is the airway pressure at which gas begins to leak audibly around the cuff. It limits the device to spontaneous ventilation or low-pressure positive pressure ventilation, and makes it unsuitable for patients with reduced compliance who require high inflation pressures.
Indications for the classic LMA.
Routine elective surgery of short to moderate duration, in fasted patients at low aspiration risk, ideally undergoing surgery in the supine position. Difficult airway as a rescue device, both in the can't intubate, can ventilate pathway of the Difficult Airway Society guidelines, and as a conduit to fibrioptic intubation. Cardiopulmonary resuscitation, when tracheal intubation cannot be performed by a competent operator within minutes. Anesthesia for short procedures outside theatre, radiology, cardiology, dental, where minimal disturbance is desired.
And contraindications.
Absolute and relative. Absolute, patients at significant aspiration risk. A non-fasted patient, untreated symptomatic gastroesophageal reflux, gastric obstruction, hiatus hernia of significant size, late pregnancy beyond about 14 weeks, recent significant trauma with full stomach, ileus or bowel obstruction. Relative, patients with reduced pulmonary or chest wall compliance requiring high airway pressures. Morbid obesity, severe asthma, chronic obstructive pulmonary disease with high resistance, restrictive lung disease, pregnancy. Also relative, surgery in the prone or lateral position. Surgery near the airway where access for reinsertion would be impossible, prolonged surgery, and surgery requiring controlled ventilation at high pressures, or with positive end expiratory pressure greater than 10 centimeters of water.
Now, insertion. Walk me through the technique.
Standard insertion as described by brain. Preparation. Confirm patient identity, fasting status, consent. Check the device, cuff integrity by inflating with a syringe and looking for any leak. Then fully deflate the cuff and lubricate the posterior surface of the mask with a water-based lubricant. Adequate depth of anesthesia is essential. The LM is poorly tolerated at light planes and provokes laryngospasm or coughing. Position, the patient in the sniffing position, flexion at the lower cervical spine, extension at the atlanto-occipital joint, as for tracheal intubation. Insertion, hold the LM like a pen, with the index finger at the junction of the cuff and the tube. With the other hand, extend the head and open the mouth. Press the mask against the hard palate with the finger and slide it backwards along the palate, then down the posterior pharyngeal wall, following the curve of the airway, until definite resistance is felt. The mask has come to rest against the upper esophageal sphincter. Inflate the cuff to a pressure of 60 centimeters of water or to the recommended volume. The device should rise slightly out of the mouth as it seats correctly. Confirm placement. Chest rise, equal breath sounds, capnography with a square waveform, no audible leak at 20 centimeters of water inflation pressure, and the black line on the tube facing the upper lip. Secure with tape and a bite block.
And if insertion is unsuccessful?
I would not persist with repeated forceful attempts. Consider deepen anesthesia, reposition the head, lubricate again, try a different size. Consider the rotation technique, inserting the device upside down and rotating it through 180 degrees, or consider the digital midline technique with a partly inflated cuff. After 2 failed attempts, escalate either to a second-generation device, a different operator, intubation, or following the difficult airway algorithm.
Move on to second-generation devices. What defines a second-generation supraglottic airway?
A second-generation supraglottic airway is defined by the presence of specific design features intended to reduce aspiration risk and improve seal pressure. The hallmark feature is a gastric drainage channel, a separate lumen running through the device, terminating at the tip of the mask in the upper esophageal sphincter, through which a gastric tube can be passed to drain stomach contents and to vent regurgitated material away from the airway. Second-generation devices typically also have an improved oropharyngeal seal, usually 28 to 32 centimeters of water, and design features that reduce mask rotation and improve fit.
Tell me about the LM, a Pro Seal.
The LM, a Pro Seal, introduced in 2000 by Archie Brain, was the first true second-generation supraglottic airway. It has 3 principal innovations over the classic LMA. A dual cuff, a deeper bowl and an additional dorsal cuff behind the mask, which presses the device forward against the laryngeal inlet, improving the seal. A drain tube, a parallel esophageal channel running alongside the airway tube, terminating at the tip of the mask, allowing passage of a gastric tube of up to size 16 French. A built-in bite block integrated into the tube. The seal pressure is typically 25 to 30 centimeters of water, significantly higher than the classic LMA, and the device is reusable, made of silicone. It is supplied with an introducer to assist insertion.
And the LM, a Supreme.
The LM, a Supreme, is the single-use second-generation device from the LM company, introduced in 2007. It combines the Pro Seal's drainage channel with several practical improvements. The airway tube is precurved in an anatomical shape, eliminating the need for an introducer and allowing single-handed insertion. The cuff is wider and shorter, providing a higher seal pressure of around 28 centimeters of water. A built-in bite block and fin at the proximal end aid stabilization. It is made of medical-grade PVC and intended for single-use only.
Now the eye gel.
The eye gel, introduced by Intersurgical in 2007, is a fundamentally different design. It is made of a soft, gel-like thermoplastic elastomer, styrene ethylene butadiene styrene, or SEBS, that is anatomically preformed to mirror the shape of the perilaryngeal and hypopharyngeal structures. It has no inflatable cuff. The seal is created by the soft mask molding to the surrounding anatomy at body temperature, which means there is no risk of overinflation injury, no cuff to monitor, and no pilot balloon to leak. It has a gastric channel with an integral epiglottic rest, and the size of the gastric tube accommodated depends on the size of the eye gel, up to size 12 French for size 3, 14 French for size 4, 15 French for size 5. Seal pressures are typically 24 to 30 centimeters of water. It is single-use only.
Advantages and disadvantages of the eye gel.
Advantages: rapid insertion, typically faster than cuffed devices because there is no cuff to inflate, no cuff overinflation injury, no pilot balloon failure, consistent seal pressure regardless of operator, easier teaching and high first-pass success rates in inexperienced hands, and a wide bore that accommodates a tracheal tube up to size 7 for blind or fiberoptic-guided intubation. Disadvantages: the fixed size and shape mean it is less forgiving of anatomical variation than a cuffed device, where cuff inflation can compensate. Reports of pharyngeal mucosal injury with prolonged use. Unlike other supraglottic airways, it is not a definitive aspiration-proof airway, although the gastric channel reduces risk.
And the LM, a protector.
The LM, a protector, is a more recent second-generation device, introduced around 2015, combining features of the ProSeal and Supreme with novel additions. It has a dual gastric channel, 2 drainage ports, 1 continuous and 1 for active suction, and integrated cuff pilot technology that displays the cuff pressure continuously on the pilot balloon, with color-coded zones indicating safe pressure ranges. It also provides one of the highest seal pressures of any supraglottic device, up to 40 centimeters of water in some studies, which makes it attractive for patients requiring controlled ventilation at modest pressures.
Tell me about the LM, a fast track.
The LM, a fast track, also called the intubating LMA, was introduced by Archie Brain in 1997. It is designed both as a primary airway and as a conduit for blind or fiberoptic-guided tracheal intubation. The key design features are a rigid, anatomically curved metal airway tube, shortened and widened to accommodate a tracheal tube up to size 8, a metal handle for one-handed insertion and manipulation, an epiglottic elevating bar instead of aperture bars, which lifts the epiglottis as the tracheal tube passes, and a dedicated silicone-tipped wire-reinforced tracheal tube designed specifically to pass atraumatically through the device. It allows blind intubation with a success rate of around 80% on the first attempt and over 95% within 3 attempts, although fiberoptic-guided intubation through the fast track has a much higher first-pass success and is the technique of choice when fibroscope is available.
Where does it sit in the difficult airway guidelines?
It features prominently in the Difficult Airway Society guidelines as both a Plan B rescue device in the unanticipated difficult intubation and as a planned primary technique for known difficult airway. Its principal advantage is that it can be inserted with the patient in a neutral or even immobilized cervical spine, and provides a definitive route to tracheal intubation without further laryngoscopy.
And the LM, a gastro.
The LM, a gastro, is a specialist device introduced in 2016, specifically designed for upper gastrointestinal endoscopy under general anesthesia. It is essentially a second-generation supraglottic airway with an integrated endoscope channel running parallel to the airway tube, allowing simultaneous airway maintenance and endoscope passage through a dedicated port. The endoscope channel accommodates standard adult gastroscopes. It addresses a particular clinical problem, the increasing demand for anesthesia for endoscopy, where shared airway access between the anesthetist and endoscopist has traditionally been challenging.
Any other specialist variants worth mentioning?
Briefly, LM are flexible, a wiry enforced airway tube allowing flexion away from the surgical field, useful for ear, nose and throat and ophthalmic surgery. LM are unique, the single-use disposable version of the classic LMA. LM are Classic XL, a reusable device specifically designed as a conduit for fiberoptic intubation, with a removable connector and epiglottic elevating bar. Ambu Aura Gain and Ambu Aura I, competing second-generation devices from Ambu with similar functionality to the LM range, the Aura I being designed as an intubating conduit. AirQ, another intubating supraglottic airway with a wider bore and removable connector.
When you choose a supraglottic airway for a case, what factors influence your choice between a first-generation and a second-generation device?
3 factors. Aspiration risk. For any patient with even modest aspiration risk, I would choose a second-generation device for the gastric drainage channel. For a fasted, low-risk patient, the classic LM remains an acceptable choice. Ventilation requirements. If positive pressure ventilation at pressures approaching 20 centimeters of water is needed, a second-generation device with its higher seal pressure is more reliable. Patient factors: obesity, gastroesophageal reflux, hiatus hernia, anticipated difficult mask ventilation, anticipated difficult intubation, all favor a second-generation device, and in modern practice many centers have moved to second-generation as the default.
Can you use an LM for positive pressure ventilation?
Yes, with caveats. Both classic and second-generation devices can be used for positive pressure ventilation, provided airway pressures are kept low. I would aim for peak inspiratory pressures below the device's oropharyngeal leak pressure, typically below 20 centimeters of water for the classic LMA, and below 28 to 30 for second generation. This usually means tidal volumes of 6 to 8 milliliters per kilogram of ideal body weight. Respiratory rates adjusted to maintain end-tidal CO2 around 40 millimeters of mercury, and modest PEEP of 5 centimeters of water. If higher airway pressures are required, for example, in an obese patient or in laparoscopy, the second-generation devices are preferable, and intubation should be considered if seal pressures are exceeded.
What about laparoscopic surgery?
This is increasingly common with second-generation devices, and evidence, including from large series, supports their use in selected patients undergoing short laparoscopic procedures, provided the patient is fasted, the BMI is reasonable, and the surgical insufflation pressure is moderate. The Difficult Airway Society and the GBI have issued cautious endorsements, but my practice would be second-generation device only. Lower BMI patients preferred, Trendelenburg or steep head-down avoided, vigilant monitoring of airway pressures and capnography, and a low threshold to convert to tracheal intubation if leak develops or aspiration risk emerges.
Complications.
I divide them into immediate, early and late. Immediate: failed insertion, trauma to the lips, teeth, tongue or pharynx, laryngospasm, bronchospasm particularly in patients with reactive airways and light anesthesia, coughing and gagging at insertion. Early: malposition with leak or obstruction, gastric insufflation, particularly with a poorly seated device and high inflation pressures, regurgitation and aspiration, historically the most feared complication and the principal driver behind the development of second-generation devices. Airway obstruction from epiglottic downfolding, cuff herniation, and pilot balloon failure. Late: sore throat, the most common complication occurring in 20 to 40% depending on cuff pressure and duration. Hoarseness, dysphagia. Nerve injury, particularly hypoglossal, lingual and recurrent laryngeal nerves, usually from overinflated cuffs. Mucosal injury and rarely pharyngeal perforation.
What is the incidence of aspiration with a laryngeal mask airway?
Published estimates vary widely. For elective fasted patients undergoing routine surgery with a first-generation LMA, the incidence of clinically significant aspiration is approximately 2 per 10,000, comparable to the figure for tracheal intubation in the same population. For second-generation devices, the gastric drainage channel reduces aspiration risk further. The figure rises substantially when the device is used outside its recommended indications. Non-fasted patients, raised intra-abdominal pressure, high airway pressures, or inadequate depth of anesthesia.
How would you manage suspected aspiration through an LMA?
A structured response. Call for help. Position the patient head down and laterally to allow drainage. Suction the airway through the LMA and through the gastric channel if present. Deepen anesthesia and convert to a definitive airway, tracheal intubation, both to protect the airway and to allow suction of the trachea via the tube. Bronchoscopy and lavage if particulate matter is suspected. 100% oxygen, PEEP, and lung protective ventilation. Avoid prophylactic antibiotics or steroids unless infection is established. Neither is supported by evidence in aspiration pneumonitis. Continue ventilation until the patient is recovered, and admit to a higher level of care if hypoxemia persists. Document and debrief.
Where does the supraglottic airway sit in the Difficult Airway Society guidelines?
It is central. In the unanticipated difficult intubation algorithm, after a maximum of 3 attempts at tracheal intubation, the team moves to Plan B, maintain oxygenation via a supraglottic airway, with a maximum of 3 attempts at insertion. If oxygenation is achieved through the supraglottic airway, the team then decides whether to wake the patient, proceed with surgery using the device, or attempt fibrioptic intubation through it, Plan C. If oxygenation cannot be achieved through any supraglottic device, Plan D, the situation is declared can't intubate, can't oxygenate and front-of-neck access, a surgical cricothyroidotomy is performed.
Which device do you prefer for difficult airway rescue, and why?
A second-generation device is preferable, for 2 reasons. First, the gastric drainage channel mitigates aspiration risk in a context, emergency or difficult airway, where the patient is often not optimally fasted, has been bag mask ventilated for some time with possible gastric insufflation, and is therefore at increased aspiration risk. Second, the higher seal pressure makes oxygenation more reliable, particularly in obese patients or those with reduced compliance. Many institutions have specifically standardized on the iGel or LM a Supreme for difficult airway and resuscitation use, partly because the iGel is rapidly insertable and operator-independent.
Use in pediatrics, any specific points?
3. Sizing selected by weight, as I outlined earlier. The pediatric airway is more anteriorly placed, the epiglottis is larger and floppier, and the cricoid is the narrowest point, all of which mean that insertion technique must be careful, and epiglottic downfolding is a recognized cause of obstruction. Laryngospasm is more common in children than adults, particularly at light planes of anesthesia, and the LM must be inserted at adequate depth. In modern pediatric practice, the iGel has become particularly popular for short cases, with high first-pass success and minimal cuff-related issues.
Use in obstetrics.
Generally avoided for routine obstetric anesthesia because of the aspiration risk, but the supraglottic airway, preferably second generation, features prominently in the OAAD-AS obstetric difficult airway guidelines as a rescue device in the failed intubation scenario. In a failed obstetric intubation, the supraglottic airway is used to maintain oxygenation, while a decision is made about whether to wake the patient, proceed with surgery via the device, or convert to a surgical airway.
Use in cardiac arrest.
Recommended by the Resuscitation Council as an acceptable alternative to tracheal intubation in cardiac arrest, particularly when intubation cannot be performed by a competent operator without interrupting chest compressions. The supraglottic airway can usually be inserted without interruption of compressions, achieving an airway in seconds. Ventilation can then proceed asynchronously at 10 breaths per minute, while chest compressions continue uninterrupted. Recent trials, including Airways 2, have shown supraglottic airways to be at least equivalent to tracheal intubation in out-of-hospital cardiac arrest in terms of survival.
When and how do you remove the laryngeal mask airway?
2 schools of thought, awake removal or deep removal, both have their place. Awake removal is the default in adults. The patient is allowed to wake spontaneously, regaining airway reflexes. Once they are obeying commands and breathing well, the cuff is deflated and the device is removed in one smooth motion. Deep removal is preferred in children to avoid coughing and laryngospasm during emergence. The device is removed while the patient is still deeply anesthetized, with the cuff inflated to bring any pooled secretions out with it, after which the airway is managed by mask, until consciousness returns. Whichever approach, the patient should be positioned head up or laterally. Suction must be immediately available, and supplemental oxygen continued.
Pitfalls on removal.
Laryngospasm, particularly during the intermediate phase of emergence. Biting and occlusion of the tube, hence the bite block. Regurgitation as airway reflexes return. And dislodgement during transfer, especially in patients moved from operating table to trolley before full emergence.
Finally, what's on the horizon?
Several lines of development. Continuous cuff pressure monitoring, as in the LM a protector, with feedback systems to maintain optimum seal without overinflation. Integrated video laryngoscopy in supraglottic airways. Devices with a camera at the mask aperture, allowing direct visualization of the glottis and confirmation of position. Specialist devices for particular procedures. The LM a gastro is the first example. Further devices for cardiac, transesophageal echocardiography, and ophthalmic surgery are in development. Disposable, eco-conscious materials. The environmental footprint of single-use airway devices is increasingly scrutinized, and biodegradable or reduced plastic alternatives are being explored. And point-of-care confirmation, capnographic and ultrasound-based confirmation of correct placement, replacing the more variable clinical signs.
Last question. 5 take-home messages on supraglottic airway devices.
1. Know the generations. First-generation devices provide a perilaryngeal seal. Second-generation devices add a gastric drainage channel and a higher seal pressure, and have largely become the default in modern practice. 2. The seal pressure determines what you can do. 20 centimeters of water for the classic LM limits you to spontaneous ventilation or gentle positive pressure. 28 to 30 for second-generation devices allows more confident controlled ventilation. 3. Patient selection still matters. A supraglottic airway is not aspiration-proof, even in second-generation form. Fasted patient, low aspiration risk, supine position, modest airway pressures, anticipated short duration. These are the conditions in which it performs best. 4. The device features in every difficult airway guideline. Familiarity with first attempt insertion of at least one second-generation device, and with the fast track or another intubating supraglottic airway, is non-negotiable. 5. Measure cuff pressure where possible. Sore throat, nerve injury and mucosal damage are largely preventable complications of overinflation. A manometer is a cheap, simple intervention that saves morbidity.
Thank you. That concludes this station.